And I'm going to record. Okay, so I should be up and going now. So everything should be recorded, and I will start posting these on Moodle. So obviously these this new method, I'm going to put them up on Moodle, and I'm probably also going to, if the videos are good, I'm going to put them on my YouTube channel so that you guys kind of have access to them always, and potentially, hopefully, the theory is that they would never die. And so that would be the hope. So it's supposedly is capturing what I'm looking at right now, and it will continue doing that. So I'm going to go into Moodle and we will start the lecture. I am going to grab the lectures for today. If no one has any more questions for me, Ava and Courtney, I think I answered your question, but if I did not, let me know. We can answer that further for you. All right. Remember that we are in medical module and we are continuing from spring break. I hope everyone enjoyed their break. And we're going to move on with the trauma module. Last week we took our module exam for medical and that went pretty well. And we entered into the trauma module with bleeding control and trauma overview. And so that was 25 and 26. And so tonight we're going to continue with the rest of the trauma module. We will finish the trauma module today and to next week, and then you will take the trauma module exam. If there are any questions while I'm grabbing the lectures, just speak up.
Do we have, like, what's going to happen this week for lab?
So remember that last week we brought in the last skills. So you now have practiced every skill that you can be tested on at the psychomotor level. So remember that for this class, you will do a final computer-based exam, and then you will verify that all of your skills checkoffs have been done. So that is your classroom psychomotor exam, and then that will qualify you to take the National Registry computer-based exam and the National Registry psychomotor exam, which is conducted by the state. So all of the skill sheets have been completed. So from this moment on, your only job in lab is to practice the skills we've learned, and when you feel ready, you're going to request a checkoff. If you remember, I told you guys that the final skills checkoff sheet, every one of you have one of those. I keep it on my iPad. I monitor it. I showed it to you. And every skill that we have, when you feel like you've mastered that skill, you can ask to be checked off. And if you pass that skill in one go, you are successfully checked off for the remainder of the class. It doesn't mean you stop practicing, but it means you are checked off for that skill. Here's what happens if you don't check off for a skill. The last 2 weeks of class, you have to check them all off in one go. So it'll be a go or a not go, a pass or not pass. So you don't want to run into that scenario. Your goal from this day forward in lab is to practice the skill stations to the expert level, and when you feel you are there, request a final skills checkoff. Myself, Megan Golbus, Scott Miller, Sarah Wiggins, we can all do final verification skills checks for you. So all you've got to do is have them do it, and if they think you passed, they just let me know, and I sign you off on that skill. Okay? Any questions about how that occurs? Does everyone remember looking at that sheet? We looked at it last week in lab.
I have a question.
Yes, ma'am.
So, like if we were thinking that, like we practiced enough and we thought we were ready to do a checkoff, but we actually didn't pass, does that affect us, or do we get like another?
It means that
chance?
you can't. There's no penalty. It just means that if you try to check off and you don't make it, I won't do that again for the remainder of that day. That keeps me from people. Here's what will happen. You guys will try to check off and you won't pass. And then you'll be like, okay, can I try again? Can I try again? And then other students kind of get left behind. So the rule is, If you ask for a skills verification checkoff and you do not pass, you cannot request that again for the remainder of the night. You can keep practicing it all you want, and there's no penalty. You just don't get the checkoff for that night. Okay, so tonight we'll do 27, 28, and 29, which is soft tissue, face and neck, and head and spine. You guys have already done trauma overview and you've done bleeding. Last week's discussion board was a pretty in-depth discussion board where you covered Stop the Bleed course, which is a national course put on by a combined bodies of experts when in regard to public bleeding control, the access to the public to bleeding control supplies and training. And you guys watched a YouTube video of the actual Stop the Bleed course. You also watched a video on deploying tourniquets and how to stage tourniquets. I also showed you a video on pelvic binders, and you had a discussion board on that. So you guys had a really in-depth trauma discussion board last week. I'm not done grading those. Some of you did really well. Some of you just met the mark, which is fine. But I'm still grading those. So if you didn't do as well as you wanted on those videos, they're always there and they're always available to you. I did not assign it a lockout date, so it won't go away. If you want to see those courses again, those YouTube video links again, you just go back into that discussion board and it will be there available for you. So there's that. All right. So let's pull lectures up. Let's see if I can get 27 on there too. Didn't like 27. There we go. All right. We're pulling that up. When will those exams be? Do you mean the trauma module exam? The trauma module exam will be not next week, but the next. If you mean the final skills verification, the exam with the state is on you. So you can look those up. You basically would go to the Low Country website and you can see when their next tests are. Normally there's a test every month, at least one, if not two. So you basically finish the class and you go on and register for that test. Now, I'll go over that at a later date. This isn't stuff that you guys will be keeping up with. Yes, that is in Walterboro. Now, with that said, because of COVID, we haven't been able to put our own exam on. In the past, before COVID, we did our own exam for this class. However, when COVID came, that kind of stopped. So, as I have done for the last two classes, I will ask to do our own exam. That will be approved or denied. So I will try. I will let you guys know as we get closer to that timeline if that will be something we're able to do. If it isn't something we're doing, then you guys will go on and you will register at the Low Country website for the next NREMT basic psychomotor exam. So for those of us needing to buy flights, can we look at those dates as estimates on the website? Yeah, they're on there all the time. You can look at those dates all the time. So the most obvious is that let me screen share on here too. Screen sharing in two places. The most obvious date that we have for you guys, the one that I think, if we can't get our own exam, I would imagine. So you can come down here, you can say view all courses and events, and you can do category up here and say psychomotor examinations, and so it should tell you every one of them. So March, the last one, is not applicable to us. Neither is April. May 15th is the end of our class. And so there isn't one posted after May. So you might actually be able to get, some of you might actually be able to get into the May 13 exam, as long as you got all of your stuff done. And so this exam exists, and then there'll be one in June as well. So as we get a little closer, most of you will be able to make this psychomotor exam if you want to. However, my hope is that because the week of the 6th, the week of May 6th, we're technically done with the class. I extended it to May 15th just to cover people to make sure they weren't left behind. However, I still have everyone projected to end the class the week of May 9. So you would be done on the 12th. You could technically register for the May 13 exam, provided that you have done your final exam. So that's what will hang on whether or not you can do the May 13. But don't put your hat on that yet. Let me see if I can get us a class exam. If I can get us a class exam, then we'll probably shoot for the 14th on a Saturday, and everyone will come in, and that will be at the College of Charleston. That's typically a better deal for you guys, and it means that you get to test together as a class. And I also think that's more comforting to you as well. So, Courtney, depending on your dates, you can shoot for the 13th or the 14th and buy tickets after that. Now, Courtney, talk to me about your plans outside of class, and I can help you further. You don't have to take the test right after the class. You have 12 months from the end of class to take the psychomotor, and you have 24 months from the end of class to take the computer exam. Now, do I recommend that? That is absolutely dumb. That is not something you would want to do. If you were forced to do that, you could. So these exams, in order to certify, do not have to be immediately completed. So say you have some trip that's coming up right after class. Take the trip. We can get you scheduled for the exams after the trip. You have time. Without further ado, if there be no more questions, I'm going to pull up 27. Soft tissue injuries. Oh, I already pulled up 27. There we go. Screen share is off, and we should see slides on the screen. If you don't see slides on the screen, then let me know. So we're continuing with trauma module, as we said, and we're going into soft tissue injuries, which covers the skin. Now, as I have previously made clear, I'm not going to go over each individual piece and component of the chapter. That's your job. I'm going to cover the big information that, one, is applicable to quizzes and exams, and two, is stuff you need to know in practice. You need to do the work on reading the chapter. Okay, so I'll put that little qualifier out there again. When we talk about soft tissue injuries, we're discussing the skin. And most importantly, the chapter points out skin-based wounds, burns, which have 3 categories. We'll discuss burns, and even taking care of the eyes and the skin as far as diluting and debriding goes without contaminating other portions of the patient, depending on whatever injury they might have encountered. We will discuss that avulsions. Avulsion is basically scalping. So if you imagine a patient hitting their head on the sun board, whatever you call that, the sun visor, sun board, sunscreen, on their car, and when their head comes in contact with the sun visor, it makes a laceration and basically skins their scalp back. And that would be an avulsion. Avulsions typically aren't life-threatening, but they sure are distracting. In the trauma module, we will talk a lot about distracting injuries. Injuries that look so bad or get us so nervous that we miss other injuries, even potentially more life-threatening injuries. And avulsions would certainly fit in that category. When you think about visually upsetting wounds, that would definitely classify and put avulsions in that category. However, they're not normally life-threatening. Now, they can be quite bleedy, so they're distracting for that reason too. They require your attention. You have to get some bandaging on board. So you can deglove your fingers, your hand, your arm, your scalp. All of those would be avulsions. And if you can think of an avulsion, just think of looking down at your hand and all the skin is flapped back and all you have left is muscle, bones, and nerves and tendons and all of that. That would be an avulsion. So basically, degloving. Your book will talk about degloving, so pay attention to that. We'll let you read about bite wounds. Lacerations we'll talk about. Puncture wounds are super important. We've already discussed that any puncture wound from neck to navel, 360 degrees, gets an occlusive bandage. So we're thinking about puncture wounds to the chest, abdomen, and the thorax area in general. Not just the front, though, also the back. Any punctured wound that might have penetrated the lining protecting your lungs could potentially suck air into the chest cavity, making it difficult for your lungs to expand. You guys have already looked at pneumothorax. You've already looked at hemothorax. You know what those terms are, or you should know what those terms are. Basically, you're introducing air or blood or fluid into the space that your lungs are supposed to expand in. And if there's any fluid or air pushing against the expansion of your lung, well, it doesn't expand. And so the patient can't breathe. And if you can't breathe, you can't live. And that is where we get concerned about puncture wounds to the chest and the abdomen, front and back. Because that lining is so big, you could potentially have a pneumothorax that looks visually outside of the area of the chest. However, it still causes a pneumo. And so that's why we created that rule. Neck to navel, 360 degrees. If it is a puncture wound, we cover it with an occlusive dressing. The point of an occlusive dressing is to keep air from sucking into the chest. So there's that. Okay? Incisions, we'll discuss how they small in difference from laceration. Okay? We'll talk about burns and burn management. You do need to know that there are electrical, chemical, thermal, and radiation burns, and that's a big deal. You need to pay attention to that in the chapter. So for electrical burns, the main thing that concerns us is not the physical skin injury that you're looking at. When you get a burn secondary to electricity, it affects the breathing and the cardiac center, and it affects the brain components that run the breathing and cardiac center. So what we are concerned about most with an electrical burn patient is that they might at any moment go into cardiac arrest because it has affected their breathing and their heart, or the parts of the brain that control it. So with electrical burns, the big thing to remember is don't get distracted by the outside appearance of the patient. Pay close attention to the patients needing breathing control, needing CPR, potentially going into a cardiac arrhythmia. So I ask you, what piece of equipment do you think you need ready to go with an electrical burn patient, having said what I just said? Very good, Ariana. You need your AED. We know that if a patient goes into cardiac arrest and it's witnessed, we're right there when it happens, you should shock that patient as quickly as possible. In the medic world, we shock the patient immediately if they go into cardiac arrest with an arrhythmia that is shockable. So you guys can do the same thing. If you have an electrical burn, it is not uncommon for an EMT to put their pads on the patient, but not turn the AED on and not plug the pads in. Well, Justin, that's not what you taught us in BLS Provider. BLS Provider was the very beginning. It was the very foundation. What we're talking about now is good practice. If I know that electrical burn patients tend to go into cardiac arrest, and they tend to need immediate defibrillation, and that immediate defibrillation results in perfusion a lot of the time, then that's what you should be prepared for. There's nothing that says the experienced The up-to-date, the modern EMT cannot be educated and informed enough to make a headway on the patient's behalf. You can put the pads on the patient's chest and leave them in place, ready to go if they're needed, but not turn the AED on because it's not needed yet, right? So think about that. Remember that the problem with electrical burn is breathing and cardiac arrest. Electricity encountering a human being results in cardiac arrhythmia. Electricity encountering a human being results in cardiac arrhythmia. That's what they will probably die from, not the big ugly burn marks that you see on the outside of the patient. Okay? Chemical burns, pretty scary, huh? So if the chemical that's on them burned them, then that chemical can burn you. So step one when it comes to chemical burns is, are we safe? Is it safe to care for this patient yet? Or do they need decontamination? Does anyone remember who we said was most likely responsible for decontamination? It's not EMS. There was a group of people that we tend to rely on for decontamination of patients when they've been exposed to chemicals or any other type of hazard material, and it's firefighters. The fire departments typically, good job Ariana, they typically maintain your hazmat units. Of course, EMS providers can be involved, so can law enforcement. Tons of people can, but that's just a typical responder modality there for the fire department. So remember that with chemicals, they might hurt you. So step one, get all those clothes off. Step two, do I need to decontaminate this patient? We did speak about dry chemicals, powder chemicals. We talked about that a little bit in the environmental chapter. We discussed how to address a chemical burn related to a powder, and we said that step one was to remove all of the patient's clothing. And step two, if there's any remaining powder, we're supposed to brush the powder off. As much of the powder as possible gets brushed off. And then we irrigate the patient. So 1, expose, 2, brush the remaining powder off, 3, irrigate the patient. We said that that was important because when you brush off as much powder as possible, you reduce the chances of carrying the chemical through the rest of the patient's body. Once we start irrigating, then that's going to run the chemical elsewhere. Now, dilution is very powerful, and so will it be as much of a problem depending how much water you're flowing over the patient? Maybe not, but that's best practice, okay? So you've got to remember the steps to managing a powder-related chemical on the patient. Step 1, expose. Step 2, brush it off. Step 3, now you can irrigate the patient. You want to free the patient of that chemical, and then we can treat the soft tissue, whatever is left over of that, okay? So that brings us to thermal. So chemical and thermal, although they are caused by different things, once you get the chemical away, once you get the thermal source away, managing the burn is going to be similar. How do we manage burns? Well, typically the first step is stop the burn process. You need to know that soft tissue continues burning beyond what you can see with the naked eye. That heat is being trapped at the layer of the skin, and it's being trapped at the cellular level, and there is more tissue being harmed even after the source of the burn is gone. So we need to irrigate burns. You need to irrigate the burn area to stop the burn process. However, after that, you've got to get all that wet stuff off the patient. Because let's think about soft tissue. Your skin, what is its job? The chapter is going to talk about that. The skin's job is to keep you warm. The skin's job is to allow you to sweat when you're too hot. The skin's job is to protect you with a barrier that keeps out invading things like bacteria, fungus, viruses, plasmosis, all of those types of things. Your skin is responsible for keeping your fluid balance inside of your body and allowing only what is supposed to go elsewhere to go elsewhere. So your skin does all of that. Temperature control, barrier protection, and your fluid management. So when we burn the patient and we take that burn down to enough level to eradicate the barrier that your skin was supposed to provide, now you can't manage your temperature. Now you can't keep the fluids in the right space. So you're going to lose a lot of fluid volume out of your body because your skin isn't able to do its job. So we get very concerned with burn patients that they become cold. They become hypovolemic because they're dehydrating from this evaporating fluid that their skin normally keeps inside, but now it's not. Okay? So, step 1 with a burn, irrigate it, stop the burn process. Step 2, get all of that wet stuff away from the patient. Step 3, apply dry dressings. Dry dressings. Dry, sterile dressings. Now we're going to put some sterile, dry dressings that we hope will become a part of the patient's new barrier for as much time as they need it until they get to definitive care. Okay? And then cover the patient with blankets because remember, they've lost the ability to keep themselves warm. What percent of burn am I talking about? Above 20%. Once a person is burned in their body surface area more than 20%, that's when we start thinking this person's going to get dehydrated. This person's going to become hypothermic. This person potentially is losing electrolytes and is in harm's way. Okay? So, you need to remember what to do about burns. If they're electrical, what is our concern? If they're chemical, make sure they're decontaminated first and then you treat them. Thermal, make sure you stop the burn, irrigate them, take the wet stuff away, get them dry, and put on dry, sterile dressings over the burn. Sometimes there's so much burn you can't put individual dry, sterile dressings. And so what would you do in that case? Well, we have these big burn sheets. They're like a blanket on your bed, except it's kept sterile in a package. And that sterile blanket can go directly over the patient to provide one continuous barrier over the patient. We have a couple sterile burn sheets in the classroom that you could look at. It literally looks like a bandage, but it's body size. And it comes in a sterile package so that when it touches your skin, you're not exposed to any contamination like bacteria, fungus, viruses, plasmosis, stuff like that. Okay? Radiation. With radiation, what's done is done. You can treat the skin and the soft tissue the same as you would treat the skin and soft tissue of the other burns. However, radiation is nasty in the way that whatever is radiated, and it's going to be whatever the damage is acutely, and then that damage will grow over time, potentially causing, pretty horrible death. You need to remember in the world of radiation something called TDS. What helps patients with radiation? Time, distance, and shielding. You need to put as much time between you and the boom. You need to put as much distance between you and the source. And you need to put as many things, houses, cars, lead-based things between you and the source. Time, distance, and shielding. The further you are away in time from the source, the less radiated you will be. The further in distance you are, same thing, and the further you are with shielding. So what is between you and the source? That's what you need to remember with radiation. Time, distance, and shielding. Okay? Let's talk about the degree of burns. Okay? Let's talk about the degree of burns. Remember that we're focused on the soft tissue. And so when you get burned in 3 different degrees, potentially 4, but the 3 that matter are 3 degrees. It used to be called first, second, and third, but you'll notice that the book doesn't use those terms anymore. It's not first, second, and third. So now it's called superficial. That means that it's like a sunburn, right? There's no blisters. It did not break the barrier. It hurts like hell. You can't sleep, you can't put on a shirt, and over the next few days you end up sloughing off your skin. But superficial, think that super red sunburned patient. But there's no break in the barrier. So there's no blisters. There's no obvious wound to the skin. Then we have partial thickness. The best way to know you have a partial thickness burn is it causes blistering and popped blisters. So if you see popped blisters or blisters, then you know it's a partial thickness burn, or what we used to call second degree burn. Partial thickness burn counts. Superficial does not. If a person is sunburned from head to toe, on a general basis, we would not count any of that burn. Why? It didn't actually injure and take away the barrier. They're still able to control their temperature. They're still able to control their fluid management. They're still able to keep out bacteria and viruses. So then we don't count superficial. We don't count first degree. We don't count sunburns. But the moment that you cause blistering or you ruptured blisters on the skin, now you actually are enabled to control temperature and to control your fluid balance and to keep out bacteria and viruses. So that's when the burns start to count. And so that's partial thickness is blistering. And then full thickness is once the entire layer of skin is burned. This is black, charry, leather-looking skin. The book has pictures of each one of these levels. Again, my job is to teach you the stuff to go looking for. Your job is to do it, okay? So when you think about burns, superficial, partial thickness, full thickness. Superficial and partial thickness hurt like hell. Full thickness burns burn the nerve endings and they don't hurt. So some people get very confused when they look at a patient who is badly burned from head to toe and that person's talking and they're like, I'm okay, I'm all right. And you're like, how the hell are you okay and all right? The answer is they've burned those nerves. There are no nerves sending signal to say, oh my God, I've been burned. And so some of the worst burn patients I've ever seen acted and behaved like they weren't in a lot of pain. They're clearly at great risk. They're clearly at great risk of dying, but they've burned the nerves. So when you think about how do I spot the difference, partial thickness hurts like hell and it's blistery and seeping and there's fluid and skin kind of bubbling. Full thickness looks like leather. And it can be dark gray and black and super brown looking. And that would be a patient who's burned all the way down past the nerve, okay? We used to have fourth degree. We don't really talk about it a lot anymore, but because it's kind of obvious and there's nothing to really do. Fourth degree is when you burn it all the way down to the bone. If there's no skin at all and you can see the bone, that would, in the old days, have been fourth degree burn. But we don't really classify that anymore because there is nothing pre-hospital of value there. It has a high mortality rate to be burned in the fourth degree. So does full thickness for that matter. So things to remember. Those are the 3 degrees of burning. Know the difference between electrical, chemical, thermal, radiation. Know that full thickness and partial thickness burns above 20% start to really increase the patient's potential for mortality. Okay, that's when we start to get concerned, is when the body surface area is above 20%. Okay, so then let's talk about how you manage finding out if the patient's body surface area is above 20%. Okay, you're going to find the rule of 9s in here. Let me see if I can find the rule of 9s. That's an evisceration. We'll talk about that in a minute. Okay, so here's your pictures of the difference. I'll let you look at those. We've already talked about it all. And this is the rule of nines. So your questions probably immediately, well, do I have to learn the rule of nines? Well, yeah, you do. You're going to see a couple questions, not a lot of them, but a couple questions of the rule of nines. It's much easier to do in an adult, okay? So I would certainly expect you to know an adult's rule of nines, but when you get into the children world, it's a lot more difficult. You can see that their head is a lot more percent of body surface area because they have bigger heads than us. So that's something you should think about and remember. I would at minimum get the adult correct here. You are going to see some rule of nine questions. Here's something more valuable though. It is considered 1% the patient's size of hand. Okay? For every palm of the patient, not your palm, but palm of the patient, that is wildly accepted in the burn world as being 1% body surface area. So what you can do sometimes is take your hand, or the hand of the patient would be most accurate, and count how many of those you can fit in the body surface area that is burned, and that would be your percentage. Anytime we get above 20%, we start to be very concerned for the patient's well-being. Okay, so we've talked about the different types of burns. We've talked about the degree of burns. We've talked about body surface area that is burned and when it becomes of mattering. Above 20%, we start to know that the patient is at risk. Okay, so put that feather in your cap and we'll take a break there. Let's come back at 7:30. Let's take a quick 5-minute break and we'll come back at 7:30 and we'll get back to it.
You are now muted. You are now unmuted.
All right, friends. So we've learned about burns. Let's talk about crush syndrome. Crush syndrome in the book is going to be discussed as any time you smash or break enough of the soft tissue to cause internal swelling. And normally it would be closed. Another word for crush syndrome is compartment syndrome. Compartment syndrome. Why? Because you create a compartment. So imagine a vehicle tire rolls over your forearm. The damage to the soft tissue, both internally and externally, will cause a lot of swelling. Well, if there's no open laceration in your skin, there's nowhere for that swelling to go. So if it swells enough that it stops blood flow to that area, then you'll start to progress anaerobic metabolism. Anaerobic metabolism makes acidosis, and basically the tissue would begin to die. And while it's dying, it's producing a lot of acidosis that eventually might get released into the rest of your body. So crush syndrome and compartment syndrome can result in the loss of limbs and eventually, if it's big enough, even the loss of life. So you've got to remember that we're not just concerned about things we can see on the outside. If you see swelling in a confined space, let's take the calf, the thigh, the forearm, the upper arm, and it's closed internal aggressive swelling, you'd be concerned that blood flow to the area has been stopped, and because of that, the tissue will begin to die from the inside out. Big deal. Compartment syndrome is a time injury. We talk about heart attacks. We talk about brain strokes. We identify those as time-sensitive emergencies. Well, compartment syndrome is for sure a time-sensitive emergency. If you can get that patient to surgical intervention as fast as possible, we can prevent, hopefully, the tissue from dying or them losing their arm, or even worse, them becoming so acidotic from
muted.
this.
You are now unmuted.
Becoming so acidotic from crush syndrome that they could actually die. So that is compartment syndrome and crush syndrome. Real quick, let's be sneaky. Can I get hands to show everyone's in the class, listening, paying attention? You're doing what you're supposed to be doing. I'm not here for nothing. Can you put your hands up? Thank you. Where is Julia? There we go. Sarah. Where's Luke Ackerman? Bless your heart, Lukey Luke. Where is Luke? Should I put Luke on the didn't attend list? There you are, Lucas.
I'm here.
Okay. I wouldn't want you to miss a single moment of my voice, Lucas Ackerman. All right. I'm going to lower your hands. All right. Let's continue on. So that's compartment syndrome. If no one has any questions about that, we'll move on. All right. I'm making sure I hit every little thing I think is of super big importance. I'll let you read about those things. Know the difference between blunt and penetrating. It's pretty obvious, but if you don't know, penetrating goes inside and blunt is on the outside. One of the things that the trauma overview chapter talked about in depthly is energy. You have to remember that energy goes on beyond what we saw with our naked eye. You don't just stop energy. If you remember back from 8th grade physics class, energy must be acted upon with an equal or greater force if you're going to stop it. So when energy hits, let's think of a baseball bat striking someone's abdomen. The energy didn't stop when the bat contacted the patient's skin. The energy of that kinetic force transferred into the patient's abdomen and into the abdominal quadrants and into the organs that they hold. And so that energy is causing damage that you cannot see. And that's what makes it so dangerous. It even could be causing bruising and bleeding to the extent that you get compartment syndrome or crush syndrome, because all of that swelling and bleeding and bruising has nowhere to go. So blunt injuries are very concerning because we can't see what all was done by not just that initial contact, that traumatic contact, but the energy that went into the patient causing injury beyond the point of contact that we cannot see. So I hope you paid attention in the trauma overview chapter when it discussed energy and mechanism of injury. Those are two big topics that you better give a lot of your time to. Okay? Mechanism of injury is simply, how did this occur? Was it a fall from a great height? Was it a motor vehicle accident? Was it blunt? Was it penetrating? Was it high velocity, low velocity? So pay attention to those things. Barotrauma talks about our lungs, okay? Air trauma, pressure of air. And we've already discussed burns in-depthly. We talked about what the skin does. So we're done with that. Know your anatomy. That's broken down in the chapter. I'm not going to do that for you. When we discuss something as being closed or open, it means exactly that. An open injury is one in which parts that were enclosed in the skin are now visible, whether that be bone, tendons, muscle, blood, whatever. If it's closed, you don't see the inside of anything. And if it's open, you do. So if you hear us say you have an open femur fracture, then the bone is poking through the skin. And that's obviously pretty dangerous, not just for the patient, but also for us, the provider, because what do? We tend to palpate things. We tend to palpate and touch and poke and press and touch. So you don't want to get cut on a bone. So remember that, okay? If something is obviously broken and there's a big opening in the skin, but you don't see the bone, you have to wonder if the bone poked through and went back in. Be suspicious of that, okay? So I'm going to repeat that again. If you're looking at the patient's right thigh and there's this huge deformity, remember that with DCAP BTLS, we look for deformity, contusions, which are big bruises, crepitus, punctures and penetrations, burns, tenderness, lacerations, swelling. If you're looking at that right femur and there's this big, gross, obvious deformity and swelling, and there is a small circular spot of bleeding, you got to wonder if that femur popped through the skin and went back in. So be careful with that, okay? You want to make sure you get it right, because closed injuries are different than open injuries. They're both bad, but they do have different morphologies. They do have different mechanisms, and so then that comes with different patterns of injury. So we want to pay attention to that. I'll let you read about the closed injuries, but what I do want to touch on is notice here that it says when things are allowed to swell into a compartment for greater than 4 hours. 4 hours is a wildly accepted component of the literature, but you might even see some literature out there talking about the 2-hour mark. It depends how fast and how large the area of injury is, whether that time frame is shorter or longer. So 4 hours is a good number to commit to memory for this particular chapter. So think about an arm that was rolled over by a tire. If that arm is swelling inside of itself to great amounts of pressure, and that pressure is not relieved in 4 hours, you really do start running into tissue death. You start producing that massive acidosis that not only will potentially result in an injury to the extremity, the loss of that extremity, and potentially the patient going systemically into acidosis and losing their life. So crush syndrome, also known as compartment syndrome, is a pretty big deal. It's something that we have on the front of our minds and that we're paying attention to. The takeaway from trauma chapters, I think, is don't forget the injury that you can't see. Okay? I'll let you look at that. Do pay attention to abrasions, lacerations, avulsions, and penetrating wounds. Know what those are. Avulsions versus evisceration. Let me get to this slide. I want to go back to this particular slide here. Okay, this bad boy here is an evisceration. So we talked earlier about avulsion. Avulsion was that scalping phenomenon, or the degloving, where the skin rolls back and you're left with muscle and bone and tissue. Evisceration, on the other hand, is when the stomach contents protrude out I want to tell you that commonly this is more distracting than it is dangerous. Okay? It is commonly more distracting than it is dangerous. If the tissue wasn't punctured, it's intact. It's just in the wrong space, right? So what do we do about it? I want you to pay attention to the treatment of evisceration. I want you to start by noting that it is between the neck and the navel. And if that's true, then it could potentially cause a pneumothorax or a hemothorax, depending on the injury and the mechanism. So then we must treat it with an occlusive approach. So we must keep tissue that should be on the inside of us the same way your body kept it. Moist, warm, and occluded. How do we do that? Well, here's the book's version. Okay? The book's version is that you take a big dressing, maybe a moist, sterile dressing, a warm, moist, sterile dressing, and you apply it, you tape it on all sides. So therefore, it's occluded, it's not able to suck air inside the body. It's warm, and it's moist. How do we do this in real life? Saran wrap. Saran wrap will accomplish all of those things. If you have saran wrap, you'll notice sometimes that we have that on ambulances and you're like, what the hell are they doing? Packaging Thanksgiving dinner? No. Saran wrap is very good at keeping heat and moisture inside the body. Give me 2 seconds.
You are now muted. You are now unmuted.
So this is one way you can look at the book's version. I always applaud the book's version because that's what you're going to be tested on. But just know that there are many ways to skin this cat. You might find some pretty creative stuff on the ambulance to treat this. In the absence of saran wrap or any commercial application, you would just use a large dressing that was warm and moist and capable of occluding the space, taped on all sides. Okay? You're going to see test questions that ask you about keeping contents that are on the outside of the patient that should be on the inside warm, moist, and occluded from sucking air. So know the difference between an avulsion and an evisceration. All right, so back to this slide. Abrasions are like scrapes, lacerations are cuts, avulsions are skin flapping, and penetrations we've gone over. Neck to navel, 360 degrees, make sure it gets an occlusive bandage. Okay? I'll let you look at each individual one of these. Again, if it's heavily bleeding, apply pressure with good bandaging, maybe even have a hemostatic agent. We remember from the lecture material on bleeding and from the Stop the Bleed course that a hemostatic agent is an impregnated gauze that has a chemical that stops bleeding or at least promotes the body's own qualities of controlling bleeding. Okay, so give direct pressure, big bandages, try to stop the bleeding. Do whatever you've got to do to stop the bleeding. If it's on an extremity, you might have to put on a tourniquet. If it's in the jointing spaces like the axilla, the inguinal line, or where the legs and arms meet the core, then you might have to pack that space, which was addressed on the Stop the Bleed course. I'll let you read all of that. That's just reading material, which I'm not going to do for you. I do want you to note the Rice's mnemonic. Acute injury gets ice. And an injury past the 24-hour mark, even sometimes the literature might say the 48-hour mark, gets warm. Or heat compression, heat compress. So in the early stages, we're going to ice things. And as the injury meets the 24-hour mark, we're going to start to warm things. The ice reduces the body's inflammation process. And then later on, the warmth tries to give relief to some pain, give relief to muscle spasms, even promote healing post the injury phase. So remember your Rice's mnemonic. We're talking about ankles and elbows and joints and people falling and hurting and this and that and the other. So you'll rest it, ice it, compress, ice compress, heat compress, and that just puts pressure on the area. So maybe you wrap it in an ACE bandage. You elevate and you splint. Pretty easy. If you've ever worked around athletes, you're pretty familiar with Rice's. If you're not familiar at all, then you need to become familiar. This is really important. EMTs stand by football games, tennis matches, all sorts of different things they hire us to go and be at in the event that there is an emergency. And so not everything's life-threatening. You also need to know how to treat the non-life-threatening stuff. And so if someone rolls an ankle, twists an elbow, or even maybe breaks something, don't forget the Rice's mnemonic. We remember the signs of shock. Okay, early signs of shock are agitation, maybe a feeling of impending doom, increased rate of heart, increased rate of breathing, and skin changes. Those are early signs of shock. Treat patients for shock. I want to tell you guys something, and I don't know why I'm seeing this a lot, but I am. I've done a lot of testing of advanced providers lately, and I'm finding them putting nasal cannulas on patients who have high-level mechanisms of injury and high-level medical complaints. I want to remind you that the treatment of shock included high-flow oxygen, and the book's description of high-flow oxygen was 10 liters or above. Preferably, we've said in this class continuously, 15 liters a minute or more. We don't just treat patients because of their outward appearance. Maybe they look fine to you, but we have to dig deeper than that. If you're seeing tachypnea, if you're seeing mental status changes, if you're seeing tachycardia, I don't care that the patient looks stable on the outside to you, or it isn't giving you a fear factor, what we call the pucker factor, where you're, noticeably upset or scared for the patient because this is so severe. Don't forget, the early signs of shock is the best place for us to intervene. Stop putting nasal cannulas on patients who have abnormal vital signs, who have abnormal mechanisms of injury, who have high-level medical complaints. If you are concerned that this patient is serious or sick, the treatment of shock demands that the patient be put on high-flow oxygen. Yes, we target SpO2. Yes, we target the patient's vital signs and presentation. But don't forget that it takes time to lose pulse ox. Your pulse ox can sometimes be minutes behind, 15 minutes behind. Don't forget to oxygenate the patient in the treatment of shock the way we taught it to you. That's not book practice. It's not classroom practice. It's life-saving practice. If the patient shows you out of normal vital signs, treat the patient for shock. Okay? If you don't have a reason for those vital signs. All right? Impelled objects. The book might have already covered this a little bit with you, but we'll cover it again. Impelled objects are to be secured in place with a bulky dressing. Secured in place with a bulky dressing. You do not ever take an impelled object out unless it impedes your ability to control airway or compressions. Here's the caveat to that, though. When things get impelled in your body, they're up against that vasculature that's bleeding. So there is some pressure going on there that is keeping you from bleeding more because the object is making that area higher in pressure, and that keeps bleeding from being worse than it is. When you take an impelled object out of a body space, now that is an area that's free to bleed. There's nothing keeping it from bleeding. There's no tamponade effect. Tamponade means to squeeze something off until it can't do whatever it was doing. So if we're talking about tamponading a vessel, we're squeezing that vessel with pressure until it can't bleed anymore. Well, impaled objects do that. And when you take the object out, it's likely, if it's in a severe space and if it contacted important anatomy, that the patient might bleed to death. So it's pretty risky taking impaled objects out. We typically don't want to do that until the patient is on the OR table so that we could potentially open that space up and find the bleeding and stop it in the surgical environment. We can't do that in the field. So that is why we don't take impaled objects out. We leave them in place. We secure them with a bulky dressing. Well, what do you mean by bulky dressing, Justin? Well, you make a big bulky dressing around that knife or stick or sword or whatever it is so that it can't move about and cause more injury. Okay? You can take it out if you need to deal with airway, breathing, and compressions. But that would be the only reason. And you probably are causing the patient to die anyways. So it's a pretty tough conundrum to have to get into removing an impaled object. Why do you think neck injuries are so deadly? Can any of you tell me? We'll make this a lecture assignment question. So at the 80-minute mark, I want you to tell me that it's the 81-minute mark at 19:52 p.m. Why are neck injuries so deadly? Is it the bleeding that worries you? Someone speak up. What do you think?
Is it because it's near like the medulla oblongata or like near the spinal cord, which controls most of like the vital like not involuntary functions like breathing and stuff?
You know, Drewby, I don't think that's a bad answer at all. It's not the most immediate one that comes to my mind having practiced. But that's certainly a true answer. Between cervical spine 3, 4, and 5 is our phrenic nerve, which makes us breathe. And so if you did get an object in that deep from the posterior portion of the patient's neck, you potentially could keep them from breathing ever again. So yes, Drewby, that is really important. Max, what were you going to say?
I was going to say just in regards to like triage too, for the patient being able to walk, and it's like the next relationship to possible like paralysis throughout the body.
Could be. What about that big old damn windpipe, guys? Your windpipe. Your spinal cord's much smaller than your windpipe, right? You could argue all day, I think, that you're potentially more likely to hit the windpipe than you are to hit the spinal cord, because the spinal cord is protected by bones and the windpipe is not. The windpipe is a big deal. It's a big problem. So you have carotid arteries in your neck. Those are huge arteries flowing a ton of blood. And then you have your windpipe. If you even nick the trachea, it will start emitting air into the surrounding tissues. If that air swells up enough in a confined space, it could potentially crush your trachea. Not to mention that you're developing air outside of the airway, which always results in an inability to breathe. So one of the big reasons we're so concerned about neck injuries is because they're sucking neck wounds. We said neck to navel 360 degrees gets an occlusive bandage. I'm really worried when people get popped in the neck with something that you might have nicked your trachea, especially if it's a small nick that we can't see and we don't initially spot as a problem. That's pretty scary. Every time the patient takes in a breath, they're potentially pushing more air into the surrounding neck tissues. Will you do that enough to force the trachea onto itself? Can you close the airway from that? You absolutely can. So that's what scares the hell out of us when we start thinking about neck injuries, is not only the emergent vasculature that's in that space, the carotid arteries, the two veins that are deep, the external jugulars and the internal jugulars. There's a ton of vascular anatomy there that is waiting to become a problem. On top of that's this big old trachea. So the airway is a huge concern. I don't disagree with those of you who thought about the spine. That's a really good thing to think about, considering the phrenic nerve, thinking about paralysis. But I think even more so, the potential of nicking that trachea and causing closed air into that confined space. That's a big deal. So remember that any penetrating wound to the neck needs to have an occlusive bandage. You need to put your hand over that hole the moment you find it And then as soon as you can, you need to put a bandage over that hole to keep it from sucking. You're going to see a test question that talks about what would you do if you walked into a patient's house and you saw a bubbling, penetrating wound to the neck. And the answer is immediately put your hand over that wound. Do not let it suck any more air. If it does, it could potentially kill your patient. So you want to remember neck to navel, 360 degrees, gets an occlusive bandage. Maybe that's your hand at first. Maybe then it's a petroleum gauze. Maybe it's a chest seal. We talked about hyphen chest seals. We looked at those in the lab under Google Images. So make sure you fully understand what an occlusive bandage is, what types of occlusive bandages are out there, what different versions do we have, what's best, what does the academy, the trauma academies endorse, okay? What are the big groups of specialty endorse, like North American Rescue or the combat related groups? They endorse chest seals. They endorse the different types of occlusive bandages. So go out there and look at these things. Don't just read the material and try to memorize words on a page. Go get a visual. Go look at a YouTube video. See this stuff in play so that you get a depthful, something more diverse as an understanding of application. Right, I'll let you look at bite marks because that is important, but I'm not going to waste my time on it. You can read. All right, we talked about burns a lot, so I'm going to go on with that. Remember the rule of nines. Also remember, guys, that burns do not typically kill people instantaneously. I want to say that again. We would argue that burns are a distracting injury because everyone is distracted by this horrible skin burn that makes you think, God, that must hurt. That must be so painful. And we get distracted from ABCs. Okay? Don't forget that patients who get severely burned will not die from the burn. They're going to die from ABC problems. Okay? Burns take a week to die from. You lose your body temperature. You lose your fluid balance. You get infections, severe infections. Well, that takes time to die from. If you don't appropriately manage ABCs, they're going to die from that today, right now. So don't get distracted by burns. Yes, there is an appropriate way to care for burns. Yes, they are very important, knowing the difference between the types and making sure you understand how to treat burns. But don't let that distracting, ugly, painful-looking burn keep you from attending A, B, and C. Reassess emergent patients every 5 minutes. Reassess emergent patients every 5 minutes. I'll let you read the chemical, electrical, all that talk. Taser injuries, I'm not even going to really deal with that. Most people who get tased have no problems, especially people who get tased and stop fighting. Those people tend to not have problems. The statistics would say that the use of tasers is generally safe. However, there are people who die every single year from the deployment of tasers. We call tasers less than lethal mechanisms. You notice that we didn't say they were non-lethal. We stopped using that verbiage because that's not true. People die from pepper spray. People die from tasers. You can die from these things, but it isn't likely. They're less than lethal. They're not intended to be lethal. With that said, though, don't take your eyes off of them, okay? There's a reason why taser deployments typically require, as a standing of policy, EMS notification. They got to call us out there to assess the patient. Why? We need to make sure that this hasn't caused something more lethal than was intended, okay? So pay attention to that. I'll let you read about the radiation burns. You are going to see a couple questions about alpha, beta, gamma, so give that a little bit of your time. What I will tell you from the get-go is gamma is the bad daddy. The rest of them, gamma is what we worry about. It can go through the big, nasty stuff. Not that the other ones don't have importance. Look through the bandages and the dressings because you guys don't have a lot of time with that. You don't have a lot of history of bandages and dressings. I'm going to tell you right now, if all you're doing is listening to my voice in lecture, you're not getting the substance that you need in order to be a good EMT. I appreciate you giving me your time, but you have got to read your book. And so go and look and touch and poke and look at YouTube and go into the supply closet in the lab and get this stuff out and play with it. You don't have to just be doing a sheet. The sheets are for testing, and that's great. I want you to be successful at the testing. But there's a ton of stuff in that supply room that has to do with treating patients and being applicable in the field. So don't forget to sometimes take this stuff out and take a look at it, including the medications that are in there that we take out 1 or 2 times. Go look at those things so that you have a visual, okay? I always give you the first answer, that's for sure. All right, everyone remember to speak up. I want to know you're here, okay? We're going to go through this one because we have to, but you already know the answer is contusion. A young male was struck in the forearm, so that's blunt trauma, guys. That's blunt trauma. Baseball, complaining of pain in the area. Slight swelling and ecchymosis. You need to know that ecchymosis is bruising. That's the medical word for bruising. You may see ecchymosis on your test question, and you can get distracted by that if you don't know what it means. There's no external bleeding. What type of injury does this describe? Well, an abrasion would be open and bleedy. An avulsion would be too. And a hematoma is a huge bruise that's encapsulated. So the only thing that really applies here is contusion. A contusion is a normal bruise. A hematoma suggests that it is encapsulated bleeding. So think of subdural hematoma. We talked about that in the neurological chapter of the medical module. We said subdural hematomas were venous bleeding underneath the subdural space, normally venous bleeding underneath the subdural space, and that caused a hematoma. That's encapsulated bleeding. Encapsulated bleeding can cause compartment syndrome. Encapsulated bleeding can cause death. So hematomas are big, bad, and ugly. Contusions are just little bruises. A compression injury that is severe enough to cut off blood supply is called a what? We're going with D? Very good. Compartment syndrome, also known as crush syndrome. 45-year-old convenience store clerk shot in the right chest during a robbery. There is blood bubbling every time the patient breathes. What is an immediate action from us? The global answer here would be do whatever the hell you have to do to keep the wound from sucking air. Cover the wound with a bulky dressing is not going to work, right? Because that doesn't keep the wound from sucking. We want to do an occlusive bandage. So maybe we start with our hand and then we move to an occlusive bandage. Can you get a bulky enough dressing that it does cover the wound and keep it from sucking? Yes. However, a bulky dressing is not meant for that purpose. A bulky dressing is meant to absorb and stop bleeding. It's meant to help with the clotting process. It doesn't have anything to do with preventing the sucking of air into the chest. So we want to prevent air from entering the wound. What effects will the application of ice have on a hematoma? We talked about what RICES accomplishes. Rest, ice, compress, elevate. D. Vasoconstriction and decreased bleeding. Let's see. And when you decrease bleeding, you decrease swelling. When you decrease swelling, you decrease pain and inflammation. So very good. Ice causes constriction, and constriction means they won't bleed as much, because when you squeeze more, you don't bleed as much. Okay? If you had vasoconstriction and decreased swelling, that would have been a tough one to go with. But they didn't stretch you that far, so that's good. The primary reason for applying a sterile dressing to an open injury is to what? The primary reason. Notice it's talking about the fact that it's sterile, and everyone gets a little caught up in that. The reason for any dressing is to control bleeding. That's why people die. It needs to be sterile because we don't want the area to get infected. So this question is a little bit of an a-hole. And so a lot of you go immediately to the sterility of this point. But what's the reason? It said the primary reason for dressing is to control bleeding. So don't forget the reasons we do things, the big picture here, okay? Yes, sterility does reduce infection, but we're trying to control bleeding. The most appropriate way to dress and bandage an open abdominal wound which has an evisceration. It's eviscerated. We discussed the exact treatment for that. So a lot of you are saying moist, sterile, occlusive, which will also protect heat. Very good. C. A 22-year-old male attacked by a rival gang with a large knife impaled to the center of his chest. Your assessment reveals they're in cardiac arrest. What should you do? This is such a dumb question. Remember, the patient is in cardiac arrest. We said the only reason to take an impaled object out of the center of the chest would be cardiac arrest. And so sadly, the answer is A. You got to take it out. You can't do compressions with a knife in the center of the chest. So we discussed directly in the lecture that you would never want to take an impaled object out. However, the only time you can is if you need to do airway, breathing, or compressions. And in this case, the patient is in cardiac arrest. Take the knife out, control immediate bleeding, and begin CPR. That is the order of operations for this patient. We would only stabilize in place if the patient wasn't in need of compressions. Which of the following is considered a severe burn? I like this question because it gets you thinking. And most of you are going to get it wrong. Got lots of A and B. Ooh, Lord, let's surprise you. D. Can anyone tell me why it's D? Ava, you chose D. Why did you choose D? Let me tell you why Ava chose D. Because it's multi-system trauma. You have a soft tissue injury that's full thickness, that's really bad, and a fracture. We remember that fractures cause bleeding. And so anytime you have big time fractures, that's a big deal. And then you add on top of that you have injured full thickness injury to the skin. So that's two systems. That's multi-system trauma. That's what made D the worst injury. Okay? When you fracture things, you're bleeding internally. It's a big deal. You got to remember, long bone fractures are a very big traumatic injury. If you add to that another system, that's multi-system trauma, and that's why D is the correct answer. Big burn of significant injury, 5%, but it's full thickness with a big fracture. Okay? I get what their point is. I don't know that I fully agree with the 5% part, but I get their point. Multi-system trauma is important. 5-year boy burned, barbecue grill on himself, partial and full thickness, to his anterior chest and circumferentially on both arms. What percent of the body surface is burned? So let's think of the rule of 9s. He's a 5-year-old, so he's going to be in the child category. The chest is anterior, so not the back, okay, not the abdomen, so it's the chest, okay, and circumferentially on both arms. So if you're 9 on the front, 9 on the back, that's 18 and 18. I'm going to say 18 times 3 is what I'm probably going to go with. And it's a little bit high. So 18 was the chest and the abdomen. I'm going to take that down to 9. And I'm going to say 9 times 3. I would be between B and C. Are y'all between B and C? You're going to say you are anyways. So let's go over. And it is B. So why did we come up with B? 27%. Well, the anterior chest and abdomen is 18, and it says only chest. So then that's half. So that's 9. The arms are 9 circumferentially, and it said both of them. So if you were half of the arm, you would be looking at 4.5, 4.5. So we got 9 times 3. That gave me 27%. How did I remember that the chest is only 9? Because I did it with 18 plus 9 plus 9, and it didn't work. So that's how I remembered that it's half. The abdomen and the chest make up the entire 18. So here's the point. If you remember enough about the rule of 9s, you can do the math and say, well, that doesn't work. Let me go away from that. Let me go back down a little bit here and there. You have to have a reference point or you'll never get the question correctly. You don't have to have it memorized verbatim. You got to be familiar with it enough to do the math. Which of the following statements regarding chemical burns is false? Which of the following statements for chemical burns is false? Very good. We discussed that powder-related chemical burns, we should remove the dry chemical as best we can and then flush the area with water. All right, very good. We're going to take about a 5-minute break at 8:20. 8:20, we will come back. Sharp.
You are now muted.
All right. Show of hands. Keep them up. Once you press the button, leave them there. I'm missing Ava. I'm missing Mark. Mark, you with us? Leave them there. Don't touch that button again. Mark, where you at? Mark. I'll come back to Mark. That's 15, 16, 17. All right. All right, hands are lowered. Face and neck injuries. We're going to try to go through this one a little quickly. Although, make sure you're reading it. Don't let the quickness of the review make you think that it's not important, because it is. All right, let's quickly get on with it. Let me make sure I unmuted this, and I did. And this one's unmuted, and both are recording. And let's go. So we're talking about the ears, eyes, nose, and throat, the neck in general, thinking about C-spine, cervical spine. If patients have cervical spine complaints, if they have tenderness to palpation on the cervical spine, if they complain of neck and back pain with a high index of suspicion, meaning the mechanism was pretty severe, then I would be concerned about C-spine. So never be afraid to use a cervical collar. If someone's had a pretty big mechanism and you know the cervical spine is so sensitive, never be afraid to tell the patient not to twist their neck, not to turn their head left and right, not to up and down their neck, and put them in a cervical collar. Don't be afraid of that. Okay? Head, ears, eyes, nose, and throat is what we're talking
Justin,
about.
are you talking?
Yeah, I am. Do you hear me? You don't hear me? Hello?
You are now muted.
I don't
You are
think
now
we can
unmuted.
hear you.
Hello? Can anyone else hear me? Can anyone hear me? Can you hear the love tonight? Can you hear me? What about now? Can you hear me now?
Yes.
Okay, I'm not sure what happened. It looks like I'm being recorded on the other end, but not on your end. But let's go back. So again, we're talking about ears, eyes, nose, and throat. We're talking about the cervical spine, remembering that the cervical spine is pretty sensitive. If you have neck and back pain complaints, if you have tenderness to central palpation of the cervical spine, if you have step-offs or crepitus, and there's a high index of mechanism of injury, high index of suspicion that the patient could have gotten injured from whatever it is that happened to them, don't be afraid of a cervical collar. Don't be afraid to tell the patient, don't turn your head left and right. Don't move your head up and down. Protect the cervical spine at all costs. If that's manual manipulation versus a collar, whatever you need to do, make sure you're paying good attention to the cervical spine. Okay, nosebleeds. We're going to talk about nosebleeds and head and neck facial trauma. And we're going to talk about the eyes and the dental world. We know that the head, the face, the neck, it's all very vulnerable to trauma and it bleeds a lot. So keep that in mind. It can be quite distracting. The big thing is don't let that bleeding get into the airway. Something as simple as sitting the patient forward could be a life-saving intervention depending on how severe their injury is. So don't always think you need to have bandaging and tourniquets and big time medications and interventions. Sometimes it's just positioning the patient that saves their life. So don't be afraid to put people sitting forward to protect them from bleeding into their airway. This is super true about nosebleeds. Nosebleeds often bleed into the back of the throat and airway. Most of that goes down into the stomach, but it can become an aspiration concern. So lean the patient forward. We'll talk about how to treat nosebleeds in a minute. We'll also talk about what nosebleeds are normally attributed to that can be missed, and therefore a medical emergency might not be found. So we'll talk about that too. We already talked about that a little bit in the medical chapter. All right, remember that the neck is from neck to navel, so make sure you're thinking about occlusive presentation here. Think about your sucking neck wounds here. I'll let you deal with the anatomy of the occiput and the eyes. You are going to see a couple questions about the anatomy of the eye. They like to do that to you. Definitely need to know the difference between the mandible and the maxilla. Remember that the thyroid cartilage is on top. You're going to see test questions that ask you thyroid or cricoid cartilage. Well, the T is on top, so then T comes first. The thyroid is that when you hear people talk about the Adam's apple, that's what you're seeing is the tip of the thyroid cartilage, okay? And it's on top, and so then it's the first one you see. You're going to see a couple questions about the anatomy of the eye, so pay attention to that. I'm going to zoom through that stuff. You can read anatomy questions. I'm not going to do that for you. Remember, though, when you're treating eye injuries, you always want to treat both eyes because the eyes move together, right? So if one eye is injured but the other one isn't, close the other eye. Don't let the other eye be looking around. That's a pretty important thing, okay? Again, they're very vascular, the face and the neck, and this entire chapter is pretty vascular. It's going to bleed a lot. It's always important to ask trauma questions about blood thinners. Are you on blood thinners? And did you lose consciousness? Those are very typical questions that we ask patients if they've taken any type of traumatic spill or had any type of mechanism of injury, falls, blunt trauma, penetrating trauma. Are you on blood thinners? Did you lose consciousness? That is a go-to set of questions. You should always be asking those questions. I'll let you deal with dental injuries. If it's coming out, take it out. Don't let it become an airway problem. If it's in place and intact, leave it there because you might need to ventilate the patient and that will help you ventilate the patient, such as dentures. If dentures are in place and they're well fitting, leave them in place. If they need to come out, take them out. All right, let's go on. Make sure you know what DCAP BTLS is. You're going to see that again on mnemonics quizzes that we hold in lab day. You will be seeing another medication mnemonics quiz. Remember that the first one was a game and everyone got a free 100. The next two will not be. They will not be. Already talked about that. Remember with avulsions, we talked earlier about what they are and that they are distracting. Let's talk a little bit about treatment. Irrigate it, set it into place the best that you can, dry sterile dressing. That's it. That's it. They're going to get that flap of skin sewn back into place the best that we can, and it normally does very well. It'll still have vascular flow. It still gets all the good oxygen and nutrients that it needs, and it ends up healing up pretty nicely. They're going to have a nice scar, but avulsions are not the end of the world. They look way more distracting than they actually are long-term injuries, and so keep that in mind. Irrigate the area, get it good and clean as best you can with a sterile solution, sterile water, then dry that area, put on dry sterile dressings, and keep the skin the way it should have been. So if the skin's flat back, put it back where it was, and irrigate that really nicely, and put on dry sterile dressings. Remember to cover both eyes. This is the irrigation stuff that we talked about before. You can irrigate with a nasal cannula very nicely in the eyes. That's what this is nasal cannula hooked up to fluid tubing. You can pour the fluid into the cannula. Whatever the method that you're using is doesn't really matter, but they're just telling you that this works pretty well. You don't always irrigate both eyes. Sometimes you irrigate one eye. But even if you are irrigating both eyes, don't cross-contaminate. The solution that you're running through the patient's eye, hopefully, is rinsing out stuff that's not supposed to be there. So think about the runoff. Put towels here, okay? Put towels here so that that runoff is getting onto the towel, not going into the patient's ears, not going behind the patient's scalp, causing more exposure to what was uninjured skin. So think about runoff. We irrigate things typically for about 15 to 20 minutes. Your book will give you a number of time for irrigation. Pay attention to that. It's calling for 20 minutes here. Let let you read that. If stuff is impelled, leave it impelled and cover both eyes unless it's impairing your ability to do CPR. Morgan's lenses is what you see here. We don't use a lot of those. It's for irrigation. It's basically a contact lens with a tail on it. We don't really use them a lot because, you know, they're not easy. They're irritating. When you have an injury to your eye, the last thing you want is another piece of plastic in it. So we don't tend to do that. Some EMTs do get to irrigate eyes. Some EMTs even get to put in tetracaine eye drops, which will be a numbing eye drop. When you numb the eye, you potentially have a patient not moving it around as much, not wanting to stick their fingers in their eye, and that can prevent further injury. So you might go work somewhere in other states that allow EMTs to do numbing eye drops, so that might be a potential for you. It's kind of going to talk a little bit about Morgan's lenses and how to irrigate with that. All right, epistaxis is a nosebleed. You need to know that. Nosebleeds need to be stopped by putting direct pressure and gauze over the nose. Squeeze it tightly and leave it there for 15 to 20 minutes. Don't check the nose. The most common reason noses keep bleeding is because we keep wanting to check it. You need to be at least 15 to 20 minutes into holding it there before that clotting factor has really started to take hold and you're getting somewhere. So don't keep checking it. Don't let them keep checking it. And lean the patient forward. Don't let them put all of that bleeding back into their nasopharynx, oropharynx. Even if they're swallowing that blood and it's going into the belly hates the caustic nature of blood, and it will vomit very quickly blood products. So you don't want them putting a lot of blood into their stomach. Even if that's better than putting it into the airway, it still can be pretty bad for the patient. It can be resulting in vomit. So lean the patient forward, really good firm squeeze. Don't check it. 20 minutes, let that bad boy get good and clot it off before we take a look at it. And don't be afraid to take these patients to the hospital. You also see we put tampons in the bleeding bag, and everybody's like, what the hell is a tampon doing in the bleeding bag? Well, we call those rhino rockets for a reason. You can put a tampon in the nose, and it will cause really good compression of that space, and you can then squeeze the nose too. It helps speed up the process. They're pretty good for nosebleeds. So there's that. So if you see tampons in the bleeding bag, you know why. Nosebleeds are commonly caused by high blood pressure that goes untreated and potentially can cause a medical emergency. You should always be concerned if the nosebleed isn't from trauma. If they tell you they smacked their nose with a baseball or with a basketball and then it started bleeding, well, that one's pretty easy. But the patient who has a spontaneous nosebleed, I'd really be concerned that that's from untreated high blood pressure, which can cause strokes, which can cause other big medical emergencies. So be careful with that. If the nose is bleeding, you now know what to do. Do know what epistaxis is. You're going to see some anatomy questions about the ear, especially the difference between what anatomy is in the outer, middle, and inner ear. So please make sure you have a general understanding. This isn't much. This is not very in-depth. This is pretty easy. You need to know what's on the outside and what's on the middle and what's on the inside, okay? Generally, the inside is going to be isolated to the cochlea, which is your important feature. That's what we determine. That's the message center receiver. What is the sound that I'm hearing? That's happening there, okay? The middle ear is your hammer, anvil, and stirrup, okay? Like a horse riding stirrup. So know those anatomy parts. We already talked about dental injuries. We already talked about laryngeal injuries. The penetrating ones are kind of obvious and dangerous. What's not as obvious is when you have blunt force trauma to the throat. So pay attention to this slide a little bit. Hoarseness, coughing that wasn't present before the blunt trauma, that would all be very scary, okay? Difficulty swallowing, very scary. You got to remember that that blunt trauma is going to now start to swell. And as time goes on, the swelling increases. How much swelling will we get? We don't know. How much swelling does the patient end with? We don't know. So you'd be out of your mind to let a patient with a blunt trauma to the larynx or the throat or the trachea area refuse. If at all possible, I would talk that patient into going, because as time goes on, that injury might get worse and result in airway compromise. Well, as per the usual, I give you the number one answer. Which of the following statements regarding the Adam's apple is false? It's inferior to the cricoid. We know that inferior means below, and that's not true. The Adam's apple is the thyroid cartilage, and the thyroid cartilage is superior to the cricoid cartilage. So this is one of those anatomical space questions. So you not only need to know anatomy, you also need to know directional points from anatomy verbiage. So some of you hate these questions, and I can understand why, but you've got to be able to speak like this. You've got to be able to find the anatomy and understand the anatomy with some fluency. So thyroid comes on the top. That is what the Adam's apple is the pointy end of the thyroid cartilage, and it is above, superior to the cricoid. The globe of the eye is also called the what? And don't get too deep. Come on, people. The globe is the big thing. It's the eyeball. It's the eyeball. Some people say orbit because it's also the big open round thing, but that's the bone. The orbital space is the bony space that the eyeball sits in. The globe of the eye, the big white part that houses everything, that is the eyeball. When a person's looking at an object up close, the pupils should what? Well, we know they don't remain the same. So if you get up close, you need to focus. How do you focus? You focus on constricting. Remember that dilation lets light in, and it's what we use when we're looking from things far away. You need as much light as possible to see things far away. So then the eye opens the window as open as the window can be. So when things are up close, you're right there. You don't need as much light. And so the window closes. That's how I remember this. When I'm talking about toxicology, when I'm talking about strokes, when I'm talking about the normal physiology of the eye and how the brain is, the optic nerve specifically is controlling that, I think about a window. And what's the purpose of the window? The purpose of the window is to let light in. And when we're looking at things from far away, we need as much light as possible so it's dilated. When you're looking at things up close, you're right there in front of it. You don't need as much light. So then it constricts. The window closes. When caring for a chemical burn to the eye, the EMT should Yeah, we talked directly about not letting the other eye get injured, and even more so not letting any other of the patient's head or neck or face tissue get injured by the runoff of the irrigation. So you always want to protect the runoff of irrigation from injuring anywhere else on your patient. Which of the following signs is least indicative of a head injury? Very good, because we are supposed to constrict our pupils when a big bright light is shined into them, because we don't need all that light, so then the window closes. The purpose of the eustachian tube, that's a good one. Most importantly, we're talking about the equalization of pressure. Yes, they do allow the movement of fluid, and if there is too much fluid, that eustachian tube is responsible for putting that fluid into drainage spaces. But most importantly, the eustachian tubes equalize the pressure in between the middle ear and the external atmosphere. And so that would be important. If it said that they allow excess fluid to drain, D might be more correct, but it doesn't house fluid, doesn't hold fluid. Equalizing pressure would be the most correct answer here. When caring for a patient with facial trauma, the EMT should be most concerned with what? We talked directly about this. Yeah, don't let all that bleeding get into the airway. The presence of subcutaneous emphysema following trauma to the face and throat is most suggestive of. Let's see if you can answer this. We've talked about what subcutaneous emphysema is before, and we didn't mention it today, even though we talked about the injuries that cause it. We didn't mention it today. Do you know what subcutaneous emphysema is? It is the feeling of Rice Krispies underneath your skin when there's little pockets of trapped air. So if you press on the neck and you press on the chest and you felt Rice Krispies underneath your skin, you were crushing Rice Krispies, then you would be talking about tracheal injuries. When you think about sucking wounds, anytime that air gets trapped underneath the skin, it's going to be subcutaneous emphysema. Sub means under, cutaneous means skin, and emphysema means rigid air-filled pockets, basically. So that's the presentation that you would see associated with an open trachea or lung injury. Okay, so upper injury to the breathing highways results in subcutaneous emphysema. You need to know that. You puncture the trachea, you have a bronchial trauma, you might be seeing some subcutaneous emphysema. And it's kind of the craziest thing you can feel on the planet. Sometimes a patient blows up like a fish, and then sometimes it's really subtle and you feel it. I've seen subcutaneous emphysema in the lung space, where you have a pretty sizable pneumothorax and you have an injury to the actual lung itself. And I've also seen it in the tracheal world. And both of those places, when you press down on the patient's skin, it feels like little bitty bubbles being popped underneath your fingers. Interesting enough, this week in lab, Megan Golbus from the EMS team, she wouldn't mind me telling you this because she's been running around letting everyone feel it. She had a pacemaker put in, and she has a little bit of subcutaneous emphysema around her pacemaker where they had to go past the peritoneal lining and put this pacemaker in. And they caused a smidge of a pneumothorax, which is not unheard of. It's not ideal, but it's not unheard of. And it generated some subcutaneous emphysema, which will most likely resolve on its own. So this week, if you're at Wednesday's lab and Thursday's lab, I think she's going to be at both, but Wednesday it's going to be shorter. Ask Megan to feel her subcutaneous emphysema. It's pretty cool. And you're going to find that it's more subtle than you would imagine it being. A 21-year-old male has a large laceration to the neck. You assess him. You note that it's bright red, spurting blood from the left side of his neck. What should you do? Yeah, immediately cover that wound. I would use my hand first, and I would move to dressings as quickly and as best that I could. And so the point here is one comes before the other. I don't know that applying a dressing is the wrong answer, but it's not the fastest response. A pressure dressing, though, is probably the wrong verbiage. Pressure dressing would not be great if you're pushing into the neck. So you got to be delicate there. There's a balance. Do you need some pressure? Yes. Is too much pressure a big deal in the neck? Well, heck yeah. You can't compress the airway. So you got to think about that. C is the best immediate response. Yeah, very good. You're going to get a lot of questions about hanging and what does hanging cause. So let's just quickly address that. People tend to believe that hanging causes asphyxia. Not really true. Can you have a mechanism that is the primary cause? Yes. But if you think of hanging in the original sense, let's take the capital punishment hanging. We didn't kill the patient by asphyxia. We killed the patient by interrupting the phrenic nerve's stimulation of the diaphragm. We broke their neck, right? So they had this little platform under their feet, and the platform would drop out, and they would fall a set amount of height, a very specific amount of height, and that would cause either tracheal trauma, which would immediately result in death, or it would break their neck, immediately resulting in death, because you've interrupted the stimulation to the diaphragm. So think about that when you see questions about hanging. We're worried about the cervical spine. We're worried about tracheal trauma. That is what will cause the patient to die faster than just being constricted at the neck space enough to impede breathing. That's not very common. Now, if someone's choking you, that's more common, but not so much in hanging. Okay, take a 5-minute break, and we will be back. Let's do 8:55. 8:55, a little more than 5. 8:55.
You are now muted.
me go turn on the other recording microphones. All right, let's continue this crazy lecture. Head and spine injuries. Well, let's not deviate from the process here. Everyone put your hands up. Put your hands up. Play my song. I don't know why Miley Cyrus comes right to mind. That's probably not normal. And that is everybody. Strong work. Remember to never put it down until I lower it. There we go. All right. Head and spine. Obviously, palpate the head and spine. Looking for DCAP, BTLS, deformities, contusions, crepitus, abrasions, punctures, penetrations, burns, tenderness, lacerations, swelling. Okay, so you got to palpate. Remember that in the trauma exam, in the secondary, you literally are supposed to touch the patient every little spot of their body from head to toe. So palpate. Go looking for these things. Take manual stabilization of these patients when you suspect that the mechanism is bad. When you hear information that worries you, get that manual stabilization of the C-spine early. You can always let it go if you don't need it later on in the exam, but you can never make up for the time you weren't holding it. So keep that in mind. We've talked about a good bit of this stuff as far as the life threats go. However, let's just make sure there aren't things we didn't hit, okay? Skull fractures, they're going to be open or closed. Never spend too much time trying to figure out if a skull fracture goes past the skull bone. You should never put your fingers inside there. You should never be palpating around there. The moment you note instability, the moment you realize that's a big injury on the head, that's it. Don't try to go any deeper than that. Obviously, we don't want to cause any more injury. We'll talk about some TBI stuff, spinal cord injury, which we also already talked a little bit about in regards to head and neck. We'll cover again the brain, the spinal cord, the nerves, which we already know the anatomy for. Make sure you know the frontal lobe, the occipital lobe, that means the front and back. The parietals are on the side of the head. Make sure you know that. Do note the difference between the central nervous system, which is the spinal cord, versus the peripheral nervous system, which goes out to our arms and legs. Okay? Remember that the spinal cord stops below cervical spine in the lumbar, okay? So you have cervical, you have thoracic, and you have lumbar spine, and past into the lumbar, we don't really have any more spinal cords. So make sure you know where the spinal cord begins, where it ends. That's important stuff. You know what these do. We're back to cerebrum versus cerebellum and brainstem. In the neurological chapter, you had some anatomy questions about that. You might see those again. What is the cerebrum versus the cerebellum? We know that the cerebrum is the big brain, right? That's the big white and gray matter on the right and left side. And then the cerebellum is underneath the big brain, and we call it the little brain. And then the brainstem is your medulla oblongata, your pons, which controls your breathing. So remember that, okay? Big brain, little brain. Notice the spaces in between the brain and the skull, okay? Subdural, epidural, remembering the difference between those bleeds, okay? A stroke is a stroke, whether it's traumatic in nature or it's spontaneous in nature, whether it's occlusive or hemorrhagic, a stroke is a stroke. And when you fall at, 1 in the morning and you're 80 years old and you hit your head and now you have a brain bleed, that is a trauma alert. It is a neuro alert. They're the same. They're very life-threatening. And so just remember how those words go in and out to fluency, okay? It is a stroke to have bleeding on the brain. It's also a trauma alert if that bleeding on the brain is not spontaneous. If they fell in the bathroom and they're on blood thinners, they lost consciousness, and now they're, having mental status changes. That's a trauma alert. It's potentially a code neuro. Okay, we already talked about those individual anatomical features. I'm going to remind you about the meninges. You do need to know the meninges as they progress down towards the brain. Dura is on top, and then you have arachnoid and pia. Pia is the very little layer that's on the most inner portion before you get to the brain. Cerebral spinal fluid, there's your amounts that we typically have there. Remember that when we injure the head, we don't perfuse the brain well. So you got to keep that patient's blood pressure higher than someone who doesn't have a brain injury. So you want to be responsive to shock even faster. Why? We could get back into the conversation of mean arterial pressure versus cerebral perfusion pressure, overcoming ICP, which is intracranial pressure. Okay, remember, the brain space has a pressure called ICP, intracranial pressure. In order to perfuse the brain, your body's blood pressure must overcome intracranial pressure. That causes cerebral perfusion. So, what am I saying to you? The patients who have head injuries, who go into shock, die faster and more often because you're not perfusing the noodle. So you have got to treat shock faster and more aggressively in head injury patients. You can't be letting a head injury patient go without blood pressure. They need more blood pressure than the average shock patient. You might hear us talk about permissive hypotension in the non-head injury trauma patient. You might see us say, okay, this patient's got a gunshot wound and we think they're bleeding internally in their belly. Okay, so we're going to be all right with a systolic of 92, a systolic of 96, because that's a perfusing systolic. But in a brain injury patient, I'd probably want 110, 120 because I've got to overcome the swelling brain inside that head's pressure in order to get blood up there and perfuse the noodle, which is a fascinating conversation. And it is a lot to think about when it is so different from other trauma treatment. How you treat neurological patients and how you treat brain injury patients is very different from other patients. So keep that in mind and be able to have that conversation about intracranial pressure rising and resisting mean arterial pressure. So we've got to get that map up if we're going to overcome that swelling brain pressure. I'll let you look at that anatomy there of the peripheral nervous system. Not going to really deal too much with that. You're not going to see a ton of questions about that. We're not going to ask you about dermatomes. We will ask you about voluntary versus involuntary actions. So make sure you understand what actions are involuntary, what we don't have control over. Somatic means body. And so if you're moving your arm by your own control, that is a somatic or voluntary nervous response. I made it move, right? So be aware of which processes we have that are voluntary versus involuntary. Autonomic equals involuntary. So you're talking about fight or flight, heart rate, breathing rate. Those things are controlled by the brain. Yes, you have some amount of control over your breathing rate, but in general, your brain can overpower you in a New York second, depending on its necessity to treat or compensate its own shock. So we think about fight or flight when we think about involuntary responses. Dropping that epinephrine into your bloodstream, dropping that norepinephrine into your bloodstream, beginning that fight or flight phenomenon. Know your skeletal system. We know that we have cervical, thoracic, and lumbar. Breakfast, lunch, and dinner. Cervical is 7, thoracic is 12, lumbar is 5. Breakfast, lunch, and dinner is how we come to that conclusion. You might see questions about how many are there. You need to know the answer to that. Okay? When we go into the lumbar spine, we run out of spine cord. That's why they do lumbar punctures there. That's a really cool thing to know. So while we are in this chapter, we're talking about head injuries, we're talking about neuro injuries, that's neck and spine. What is different about the vital signs of a neurological shock patient from that of pretty much any other shock? Can anyone remember that back at the 154th minute of this lecture? I want to know that it's the 154th minute lecture assignment question. What particular vital sign is very misleading in trauma patients that are traumatic neuro, traumatic head, traumatic neck, traumatic spine? What vital sign can we not rely on? Which one will be out of place? Which one will not look like shock? Do you remember? Do you remember? I would love for you people to speak up so that I know that my hard work is being received. Droovy, help me out here. I just feel in my heart you've got something. Dominique, too. She's always coming up with something. Nothing? No one? How about heart rate? In neuroinjuries, first of all, is everyone still here? No one spoke up. Are you still with me?
Yes.
Okay, thank God. I was so worried right then. My heart sank. Because how long have I been talking? Okay. It's heart rate. Remember that in neurotrauma, the brain gets cut off from all of the messages being sent from the body back to the brain. So let's say we have a thoracic spine trauma. And so below T5, we aren't talking. Well, the brain's not receiving messages that we're in trouble. And so it doesn't know to tell the body, hey, raise that heart rate. And so we see a patient who's in shock. However, they've got a heart rate of 60. Well, someone who's been run over by a car should not have a heart rate of 60. That should scare the hell out of us. Shock typically comes with compensation. We know that compensation looks like fast breathing, fast heart rates, initially hypertension. But here, this brain patient who's got brain injury, spine injury, is not showing us fast heart rates and fast breathing. They're, because of that, not showing us good blood pressures. And so the neurogenic shock patient differs from the other shocks because it does not know to compensate. It does not compensate. It is not going to raise the heart rate up because it doesn't know that they're in trouble. The message is not being received by the brain. And so the brain doesn't tell the body to go into fight or flight. So that is the big outstanding difference in neurogenic shock that you've really got to hold on to. You've really got to pay attention to the fact that neuroshock patients don't maintain shocky heart rates. They don't compensate. So you will drop that blood pressure over time because the heart rate's going to continue to fall. There's no one telling the brain, hey, we need more heart rate here. Hey, we need more breathing here. No one's telling the brain. And so that's the abnormality that you're seeing in head injury patients. When you're looking on your stretcher and you see someone that's mangled, bangled, and broken, they should be tachy. Tachy breathing, tachy heart rates, altered mental status. They should be shocky. They should fight to live. The absence of that fight might indicate neurogenic shock. Keep that in mind. I'll let you read the head injury pattern here. What I want you to take away is if the brain is injured enough that the intracranial pressure is now trying to squeeze the brain's anatomy through the head, you will see Cushing's triad. If you have brain, I don't know what I clicked on. Let me just click that out. If you have brain stem herniation from increased ICP, you're going to see Cushing's triad. That's in your book. Cushing's triad is right here. It's on the slide, 21-1. Let's talk about what happens. We smack the brain. It starts bleeding. Well, it can only bleed so much in that very confined space. So the intracranial pressure keeps rising and rising above 20, above 25, above 30. And eventually, it will try to squeeze the brain's contents through the only hole that exists there, the foramen magnum, which is at the base of the skull. When it does that, you lose the ability to control breathing and heart rate and blood pressure because that's controlled in the medulla oblongata, in the pons, in the cerebellum, in the brainstem. So your Cushing's triad is erratic breathing. Erratic breathing, however you spell erratic. I'm not even going to focus on that right now. I'm just going to put it out there. Erratic breathing, it might be, yeah, it's E. Erratic breathing, low heart rate, And eventually, we're going to start seeing some changes in blood pressure, or what we would call widening pulse pressure. Okay, so basically, they're going to become hypotensive. Widened pulse pressures means that you're getting a systolic and a diastolic that are far away from each other, right? Narrowing would mean systolic and diastolic come on top of each other. And there was a triad for that. We remember back to the medical chapter, Beck's triad was about cardiac tamponade, and it had narrowing pulse pressures where the systolic and the diastolic were climbing on top of each other. But here we have widening pulse pressures. Why? Because the blood pressure can't be maintained. And so you have this diastolic that almost fades away to nothing, and this systolic that's slowly decreasing. So you could say erratic breathing, low heart rate, and low blood pressure, but you'd be more accurate to say widening pulse pressure. Okay, so take a look at this slide, give it some of your attention. Make sure you remember that ecchymosis around the eyes, the periorbital bruising, that's called raccoon eyes, very indicative of a basilar skull fracture. You need to know that. That's a test question. And basilar skull fractures also generate Battle sign. Dr. Battle was the coining phrase for Battle signs, and it is bruising behind the ears. So if we see big bruises in the orbitus and we see big bruises behind the ear, first of all, that's not a very early sign, that's a later sign. So if you're seeing that acutely, it might go to the extent of injury. It might be indicative of how injured the fracture to the base of the skull is. But these are indicative findings for basilar skull fracture. So pay attention to this slide, because it's got to be probably one of the most comprehensive pieces of this chapter as to what a head injury looks like, what a spine injury looks like. Okay? Make sure you know what Cushing's triad is, and importantly, what to do if we see it. The only known treatment in the field currently, primarily speaking across the nation, for Cushing's triad is hyperventilating the patient. This patient's not going to be very conscious. This patient's going to be literally dying in front of your face. And the only thing that we know that might acutely reduce the pressure in the head is breathing very fast for the patient. One breath every 3 seconds. We believe that that causes vasoconstriction and might potentially buy you a very small amount of time to get the patient to an emergent craniotomy. It isn't very founded in data. It is definitely more theory than ever it is outcome-based. These patients have a high mortality. So know what Cushing's triad is, and know that the intervention for Cushing's triad, the treatment, is hyperventilate the patient. One breath every 3 seconds. If there's questions about that, bring it up. Remember to ask anyone with a head injury if they lost consciousness. Ask anyone with a head injury if they are taking blood thinners. If they've lost consciousness, it goes to the extent that they might have injured the brain itself. If you whack the brain, you'll black out. So if you tell me you lost consciousness, I'm worried that the brain took a hit. Even if you're doing well now, you need to get checked. If you take blood thinners, all of the possibilities go statistically through the roof. So there is the reasoning behind those two big questions. Nausea and vomiting after hitting your head, huge red flag. Huge red flag. Be ready to manage it. These patients will seize on you. Here is your raccoon eyes and your battle sign. Remember that the basilar skull fractures is at the bottom of the head. Everyone thinks that basilar skull fracture means occiput. I don't know why the mind incorrectly, puts you in that space, but it does. The base of the skull is across the bottom of the temporal lobe region here, along the pinna and the medial aspect of the ear. It's at the bottom of the skull, not the back of the skull. So remember that. When you have an insult, guys, to the meninges and to the base of the skull, that's when you can really start seeing Cushing's syndrome or Cushing's triad, where you're actually herniating the brain anatomy through the meninges or through the foramen magnum, or potentially through a hole that you created in the bottom of the skull via a basilar skull fracture. Really big freaking deals, and these patients are super sick. I want to remind you again about primary and secondary injury. The primary injury is the first thing that happened, okay? So the car comes to an abrupt stop, you smack your head on the steering wheel. That's injury number 1. Injury number 2 is the organs inside your head. They keep going forward. They don't just naturally stop. Remember that whole physics thing. It has to be a force that's equal or greater to acting upon it to keep it from going. So your organs don't just magically stop and stay in place. They too fly forward and end up smacking something. And in this case, it would be smacking the anterior portion of your skull, causing injury. So know the difference between primary and secondary. We've talked about that a lot. It was covered in the trauma overview. We've talked about that even in the medical module about the difference between primary injuries and secondary injuries. The inside of you is a secondary injury. It doesn't just magically stop. Traumatic brain injuries need to be ventilated. We need to oxygenate and hyperventilate these patients. If they're not showing Cushing's, then just manage the patient like normal. No gag, put in a King tube. Ventilate the patient 1 breath every 5 to 6 seconds, which is about 10 to 12 a minute. If we're moving towards the triad, then we've got to speed up to 1 every 3. I'll let you read this. The erratic breathing that we were talking about is called Cheyne-Stokes. Those are synonymous. The erratic that we're talking about is Cheyne-Stokes. Cheyne-Stokes is a breathing pattern where you breathe really fast, really slow, and then have periods of apnea. Look at that, okay? Take a look at that in the book and know that that is one of the components of Cushing's triad, is erratic breathing. There's only 2 big breathing patterns that we talk about in the EMT class. We talk about Cheyne-Stokes, which is neuro-breathing, bad neuro-breathing, and we talk about Kussmaul's breathing, which was in the medical chapter for diabetes. That was the really fast, deep breathing that we tend to see with diabetic ketoacidosis patients. Those are the only 2 named breathing patterns that we really get into in the EMT literature. So there's the only 2 you got to know. You got to really know what Cheyne-Stokes is, attach that to neuro, and the Kussmaul side of the fence, attach that to endocrine emergencies, diabetic ketoacidosis. Okay? Ataxic is, it's not rhythmic. It's maybe even stopped. Okay? It's not following a rhythm, a pattern. That would be ataxic, which also describes what might happen in the Cushing's triad world. Okay, so decreased heart rate, we know is in there. Erratic breathing, Cheyne-Stokes, or ataxic breathing. And then we're going to start looking at widened pulse pressure. Okay, widened pulse pressure. I'll tell you, in the beginning, they're going to have really high pressure. Why? Why is that systolic going to go through the roof and that diastolic is going to go way down? Well, they're physically squeezing the controlling features. That anatomy is being physically squeezed. And so there you go. That systolic is going to distance itself from the diastolic. I'll let you look again at the bleeding, dural hematoma, subdural hematomas versus epidural. I remind you that subdural tends to be venous. I remind you that epidural tends to be arterial. Epidural bleeding is very life-threatening. It's about 1% of, depending which literature you're looking at, it's about 1% of the head bleeds, and it's pretty fatal. I remind you that venous bleeding, subdural hematoma, is a slow, progressive onset of symptoms that goes into ultramentation and eventually maybe even, if unmanaged, unconsciousness. Versus the arterial side of epidural bleeding tends to get knocked out but then comes right to, and they look real good when you get to them. Here's the problem. That's arterial bleeding, and in about an hour or 2, they might be dead. Okay. The big takeaway here is you don't have a CAT scan in the field. You can't diagnose whether we are subdural or epidural, whether we're venous or arterial. Are we progressive and slow or very fast and looks okay now but dies later? You don't know. That information is good for test taking. It don't do anything for you in the field. So then what do you do with that information? It goes to your index of suspicion. Your good assessment skills makes you say, gosh, this could be a subdural. This could be an epidural. And because of that, I'm going to talk this person into going to the hospital. I'm going to upgrade this to a level 1 trauma center instead of going to a Somerville Medical Center. Secondary to knowing that this patient is elderly. Secondary to knowing that they take blood thinners. Secondary to knowing that the mechanism was high and aggravated. I'm going to not go to Somerville. I'm going to decide to go to Trident because they're a trauma center. Or maybe even I go down to MUSC because they have more neurological intervention there. So that's how this information is useful in practice and how it's useful in test taking. Concussion is most easily defined by a patient who is conscious and happy and stable with repetitive questions. They ask you what happened, you tell them, they're good to go, they get it. A couple minutes later, they ask you again. Okay, repetitive questioning makes me think concussion. Dizzy, weak, visual changes, nausea, vomiting, all those things would be suspicious for concussion. Here's the deal, though. We're back to the original argument. Do you know it's a concussion? Well, the only way to know it's a concussion is because they had symptoms, but you scanned them, and they weren't bleeding. And so maybe we even hold on to them, and we scan them in 24 hours, and they're not bleeding. So then that equals concussion. Do we know that in the field? No. So we have to be of a high index of suspicion. We have to encourage these patients to be transported and treated at the emergency room where we can get the appropriate imaging to determine which is which. We already talked a good bit about spine injuries. We talked about what we would see as far as neurological shock goes. I want to remind you what a good back assessment looks like. Consider your mechanism. Consider the location of your mechanism. Where did the patient land? Where did the blunt trauma go? Where's the penetrating trauma? Is it in the central spinous space? Big deal. Big red flag. All right. Does the patient have movement pain in the neck and back? Does the patient complain of neck and back pain with a high index of suspicion? Does the patient have palpation pain to central spine? That's a huge deal. Does the patient have tingling and numbness in their extremities, their fingers, their toes? Maybe they're not feeling their extremities the normal way. You're rubbing their leg and it's very numb. It's very light feeling. Those are all reasons to spinal immobilize your patient, or what we know to be spine motion restriction. We've talked a lot in this class about not boarding people, that we don't board people a ton. And that's true. This week's discussion board will be about why spine motion restriction in the pre-hospital setting fell out of favor. That is no replacement, though, for having done a quality assessment that reveals the necessity for spine motion restriction. Don't let the two get confused. EMS has a tendency, in fact, I would argue maybe even medicine has a tendency to find out a little bit of good information and take it too far. We can't let our knowledge about we shouldn't be spine motion restrictioning patients who don't need it. We can't take that subject matter too far and allow it to skip some of the patients we find in the pre-hospital setting that do require spine motion restriction. Never allow that conversation to be about we don't use boards anymore. Let it become we assess our patients, and that assessment will reveal whether I do or don't need spine motion restriction. You should be extremely familiar with the acronym SMR. It means spine motion restriction, and it means all of spine motion restriction. This week in lab, we will look at, again, spine motion restriction. I remind you that you cannot be tested at the psychomotor level on spine motion restriction, but you must understand that process. You must know that skill, and you must be able to do it. So don't let the fact that it ain't on the test confuse you to the realization that you are responsible for spine motion restriction. Okay, so we will learn it. We looked at it last lab. We'll look at it again this lab. You can't be tested on it, but you better practice it. I assure you, that the services that you go to work for are going to want you to be well-versed and capable of immobilizing, spine motion restricting patients with a good assessment. Let the assessment drive the decision. Remember to always take cervical spine if you are in doubt at all in the beginning of your scene size up and in your primary assessment. You can always go leave it away. You can always say, okay, I no longer need you at the head. Thank you. Do this other task. But you can't make up the time that you didn't have spine motion restriction in place manually. It costs you nothing to send a partner to hold the head in place and not let it move. Okay, it's a little bit of reading. I'm going to let you deal with that. Remember that we transport these patients to trauma centers. Not every hospital is created equal. We've talked about that. There are places who do hearts. There are places who do brains. There are places who do abdomens, GIs. There are places who do kids. There are places who do trauma. They're not the same. No matter where you go to work across this nation, you're going to have to become familiar with what hospitals are most appropriate for the patient you have right in front of your face. That comes with time. It comes with training. It comes with skill level. It comes with discernment. It comes with a good assessment driving the decision. I can teach you book stuff. I can teach you monkey skills. I can show you a sheet and say, do this. But teaching you to critically think about where to go and why to go there and how to make those moment-to-moment life-changing decisions for your patient, that's stuff you got to work on every single day of this career, no matter where you take this class. The beautiful thing about this class is it doesn't stop with you passing a test. It doesn't stop with you passing the class. This information, no matter how small or how buried deep in the chapter it might be, may become relevant for you on your very next patient. You may not have used it for a year. Well, today it is. So that's the thing about emergency medicine and critical care medicine. That's what makes a lot of us attracted to it, but it's also what makes it a challenge. Are you going to rise to that challenge? Are you going to dig into the material? Okay? When we do assess the head, neck area, remember that we are looking at the ears, the eyes, and the nose and the throat. Make sure that there's no fluids coming out of the ears. That's a big deal, especially clear or blood-tinged clear fluid coming out of the ears. That might indicate that the base of the skull has been insulted, and that is why the cerebral spinal fluid, that 125, that 150 of bathing fluid that the brain rests in, the spinal cord rests in, might be leaking out of that head. That's why we ask every single secondary head to toe on a trauma, you got to ask that question. Good for you. There's a video of a trauma assessment posted into the Moodle. It's up to you whether you want to watch it 100 times or not. If I were you, I would. That would be a component of my study material. Glasgow Coma Scale. Learn it now. I know medics who can't quote GCS, and I'll be honest, it's not always easy. And even when you are very familiar with the scale, in the moment of stress, it's not always easy. In the testing world, you're going to have to do this without a reference. In the practice world, you'll have reference. You can Google GCS and it's going to come right up for you. But you don't even have to do that because we provide a way to assess GCS in the computer that you use in the ambulance. It's probably on the wall somewhere. It's probably on your phone somewhere. There's zero reason why you can't get a quality GCS on a patient. Here's the deal. Glasgow Coma Scale talks about a patient's ability to maintain the airway. If you have a low GCS, I'm worried that you can't maintain your own airway. If you were to vomit, you'll probably aspirate. If you were to be placed on your back, you'll probably close your airway with your tongue, the most common obstructing agent of the airway. So less than 8 ventilate tends to become the thing to pay attention to here. So in the medic world, we say less than 8, probably intubate. In the EMT world, you need to say less than 8, you need to probably ventilate. And that's true. So if you're wondering, why do we care about GCS so much? Because it goes to the safety of the patient's airway. It tells us how the brain is working. Less than 8 is pretty bad. Up there in the 15 area, the 14 area, the 13 area, the patient is mentating well enough to protect their own airway. You got to become familiar with this scale. I would start by putting eyes, verbal, motor on my paper. And I would just write that until I remember it. Eyes, verbal, motor. Eyes, verbal, motor. 4, 5, 6 equals 15. 4, 5, 6 equals 15. The most you can be is 15, and the worst you can be is 3. Dead people are 3. So at a minimum, what are the components of the scale? Eyes, verbal, and motor. At a minimum, what's the maximum you can be? 15. What's the worst you can be? 3. These are at a minimum the things you should know. And here's the good thing. The 4 means there's 4 parts in eyes. The 5 means there's 5 possibles in the verbal. And then 6 is the same. That means there's 6 possible motor functions you can have. So even if you weren't super... Hey, cat, can you shut up? If y'all have ever had a Sphinx, they're not cats. They're literally like dogs and monkeys. He's over here legit talking in the hallway. So even if you don't know the scale verbatim, you can write that down on paper and get pretty close, guys. If you get a GCS question on the National Registry exam, write it out. Do not try to do it in your head. If you're that good and you really studied it, great. Most people aren't. Write it out. Okay? We'll practice this a little bit. If you guys remind me, we'll do this a little bit in the lab, and I'll show you how I do it. I always write it out. Now, in practice, I'm talking about taking the test. In practice, you pull up a reference. That's it. It's just that easy. The same thing with race score. Do you need to be familiar? Yes. Is it very important? Absolutely. Do you need to have most of it memorized? Yes, you do. On the actual patient, when you're in stress, do I want you trying to guess? Absolutely not. Pull up the reference and use the reference. Okay? I already told you about decap BTLS. You better be able to spit decap BTLS out like it was your calling from Jesus. There's no reason, no excuse for you not knowing what decap BTLS means. All right, remember the potential for hypovolemia always as our shock component, okay? Cushing's triad, widening pulse pressure. Initially, we're going to see a super big systolic going far away from that low diastolic, low heart rate, and crazy breathing. Crazy breathing. Maybe it's time to hyperventilate the patient for Cushing's triad. I'll tell you. The hyperventilating thing, as I said earlier, is debated. Okay? Your book here isn't seeming to suggest that that's an appropriate intervention. However, that's the only intervention left. And so if the patient is in Cushing's triad, there are protocols, guidelines, and standards of care still accepting that there's nothing else to do. So breathe at 1 breath every 3 seconds. Okay, read in your book about that and see what the perspective of the literature is coming from this book. Make sure you're familiar with jaw thrusts. Head tilt chin lifts are not appropriate for head, neck, and spine patients. They need a jaw thrust. We don't want to make more cervical injury. We practice cervical collars in lab. We'll do that. The KED we'll look at in lab as well. It's not something you can be tested on. That's seated spine immobilization. That's the sheet that you see, seated spine immobilization, but you cannot be tested on that. And here is long spine board immobilization. You cannot be tested on that either. But we will learn these things in class. We've already talked about it. Helmet removal. You're going to get a lot of questions about helmet removal. If a helmet's in place, well-fitting, and it is not preventing you from managing the patient's airway, leave it alone. As long as the head and neck are in a neutral position to the body. Let me give you a little more visual. If you get a 19-year-old kid on the football field, if you took the helmet off, the pads would make the patient's head flex backwards, or extend backwards. You would end up with this hyper-extended head tilt chin lift, which is obviously pretty bad, right? So you got to make sure the head and neck can be neutral. So if you're going to take off the shoulder pads, then you might have to take off the helmet. Or you've got to compensate for it with blankets, okay? So there's that conversation. So Do you take the helmet off or don't you take the helmet off? That's a big debate in the pre-hospital setting, and it gets pretty in-depth depending where you are. If you're talking to the exercise science people or the folks that take care of football athletes, they get really into the whole to do it or not to do it thing. Here's the point. If you got to manage the airway, if you've got to manage breathing and circulation problems, get that thing off. If you don't, then maybe it's best to leave it on until you have enough resources to do so safely. Why do we keep talking about it? Because it's really hard to take a helmet off without causing any of the stuff we don't like in the cervical spine. No left and right motion, no up and down motion, no pulling up on the spine. It's hard to get a helmet off without doing that stuff. So that's why it's a conversation piece. Okay? So, lecture assignment question at the 185th moment in this lecture, we're talking about helmet removal. Tell me why we are worried about helmet removal. Why is it a conversation piece in pre-hospital setting? It gives you a couple of methods here, and that concludes this chapter. So, the brain, CNS, divided into what? We've got the big brain, the little brain, and the stem. 24-year-old man, large laceration at the top of his head. You recall that? All right, let's go through them. The scalp, unlike other parts, is lower in vessels. That is a complete lie. The scalp is very vascular and bleeds like hell. So A is a lie. B, blood loss from the scalp may, anytime you see may in a question, that's a good answer. May contribute to hypovolemia. Well, the scalp is very vascular and it bleeds a lot. And so I would think that B is on the table. C, avulsed portions should be cut away. That's not what we said. We said they can be put back where they belong and irrigated and secured with dry, sterile dressings. We did not say to cut any skin away from your patient. So don't do C. That's a lie. Most scalp injuries are superficial and rarely associated with serious injury. That's also not true. Scalp injuries are very easy to cause significant damage, although there are lots of them that don't. So if I was choosing between two, I would go with B, and I would go with possibly D. Out of those answers, I agree with Dominique that the scalp is highly vascular and if left uncontrolled could potentially result in hypovolemic shock. I would say that a lot of scalp injuries are superficial and they are distracting, but heavy scalp injuries are commonly associated with serious injury. So B is more reliable in my opinion. A patient who experiences immediate loss of consciousness followed by being conscious and normal, that's what lucid means. Lucid means they've got their normal mentation, is normally associated with what? We talked about this one. We talked about this being epidural. Epidural is arterial bleeding, and epidural is the one that's responsible for immediate being knocked out. But then when you get there, they look great. And they go home and they die in their sleep. Okay? That's what epidural is. It's normally arterial bleeding. They have a period of unconsciousness followed by a period of normal mentation. Jason Eater, you raised your hand. Talk to me. Alex, you went with subdural and it does not, no, you went with concussion and that does not work here at all. Concussion is a diagnosis that we tend to arrive to because the patient has no diagnosed bleeding on CT imaging. Oh, no worries. Jason's got cats running around. 44-year-old man struck in the head, reportedly unconscious for 30 seconds, complaining of severe headache and seeing stars. He states that he regained his memory shortly before your arrival. His presentation is mostly consistent with, I don't like this question, but it is what it is. Yeah, this one would be more associated looking at the information you're given, because you can only use the information you're given, right? So from this information, what are they leading you to? Can you use the information to say it's a subdural? Well, no. Can you use the information to say intracerebral? Well, no, you can't. The only thing that the book talked about memory had to do with repetitive questioning and retrograde amnesia, and that's associated with concussion. And because of that, I would choose B. Memory and bleeding don't typically get talked about in the same question. A young male was involved in a motor vehicle accident, experience head injury. It's closed. No memory of the events leading up to the accident, but remembers he was going to the birthday party. So he remembers what was before the accident. What is the correct term when you're documenting his memory loss, which I wouldn't get into the habit of doing, but so he has no memory of the events leading up to the accident. Okay, retrograde we know goes backwards. Okay, so accident backward, he can't remember. Don't get caught up in the fact that he remembers far backwards, but he doesn't remember acutely backwards. It's still backwards. So whether you take the event and you draw a line, and the memory is either a problem on the left side going in the past or on the right side going in the future. That's how you do these questions. I don't like them. I don't think you should be digging too deep into this. This feels way more like an ALS question than a BLS question, in my opinion. But it's not that hard. If he can't remember stuff, I about said the S word, stuff before the accident, that's retrograde. Anterograde is called post-traumatic amnesia. So you are woken now, you're talking to us, and you can't remember anything. A distracting injury to the cervical spine would most likely occur following distracting injury. Yeah, hanging is very distracting, guys, and it hides what's underneath, the possibility of a cervical spine breaking or a phrenic nerve damage or even tracheal trauma. During immobilization of a patient with a possible spine injury, manual stabilization of the head can be maintained until. So let's say it says that we're going to immobilize, okay? So we've made the decision to do the whole thing. You don't let go until the whole thing is done. So you put the entire backboard on, you put on the head blocks, you secure the head, you secure the body, the whole thing is done. Now you can let go. The patient is a 21-year-old male who has a massive face and head trauma after being assaulted. He's supine, semi-conscious, blood in the mouth. Tell me your order of operations for this guy. Remember that these questions go right by the sheet, so you either do know the sheet or you don't know the sheet. Ariana Diaz, what's your question?
My bad, I didn't do that.
Okay. If you're going with A, then you don't know the contraindications of an NPA because we have massive face and head trauma. So you can't use an NPA. That's out. Suction, high flow, non-rebreather. I don't know. I don't like the semi-consciousness with a non-rebreather. C is manual stabilization. Log roll him onto his side and suction his mouth. I don't hate that because it's following correct order. Let's look at D. Apply cervical collar, suction the airway, and begin assisting his ventilations. Here's the problem I got with D. I don't know that you need to immediately apply a collar, but the rest of it is so correct. So I would definitely be between C and D. And if you're looking at this thing from absolutely correct, I would have to go with C. Applying a cervical collar would cost you time to intervene in the airway and ventilation. So for that reason, I think it should say manual stabilization, then suction, then assist. Collar would come later. For that reason, I'm going with C. And thank God they did too. And I didn't know if they were going to or not, because you never know. But that's what I would have chosen. And the reason I chose it was because applying a C collar is not necessary until you go to emergently transport the patient. You need to get a control of that airway is what you need. I hope you guys remember that, because even in our youngness of the class, we have had some people want to take that, I want to put on equipment. No, in the beginning, when you're looking at SNACM, in the beginning, when you're in the primary, you're not putting on equipment. You are taking interventions manually so that you can get to A, B, and C and fix any life threats. That's why C is so important. I hope this question really sticks out to you and gets your attention. A man is found slumped over the wheel, unconscious, snoring, automobile accident, head's turned on the side, neck is flexed. What should you do? Remember to follow the sheet. You got to deal with C before you deal with A, before you deal with B, before you deal with C. So we already know that C's out because we addressed that already. Hyperextend the neck. That's bad. He's got a neck injury, obviously. Manually stabilize the head and move it to a neutral inline position. Gosh, I love the verbiage of that. Because A is kind of getting there. It kind of feels right. However, D really gets into the meat and potatoes and says it correctly. Manually stabilize that head. You have one attempt to bring anything that's out of whack into neutral inline position. That's what you should do. You should not remove an injured football player's helmet if we talked directly about why one might leave it in place. Yeah, if there's no airway problem and you can get to the patient's face easily by taking off the guard, why go through the trouble of potentially making an injury out of something that's not currently injured? I like D. All right. Any questions for me before we say goodnight to one another? All right, let's take a roll call, because we got to do that. Yeah. And remember, I didn't call roll earlier, so I'm going to need you guys to call out here or not here. Let's load up the sheet real quick like. All right. Duplicate. Rename. Lecture 3, 1422. Enter. We did. Soft tissue. We did head and neck. Did face trauma. All right, lecture. Let's get all these out of the way. Let's turn them all white. All right. Jamie Beach, are you here? I don't think so. Jason Eater, I know you're here. Courtney Mag, you're here, right?
Here.
Sherelle, are you here? I didn't see you.
Here.
Oh, there you are. I'm sorry I missed you. Tia Davis, I did not see. Alex, are you here? You are. I saw you.
Yeah, I'm here.
Shy, are you here? Shelly Martin, are you here? Sydney Pritchard, are you here? Julia Coate, are you here?
I'm here.
Aiden, are you here? Christina Saucerman, are you here? Mark Walker, are you still here?
I'm here.
Marcus is here. Alex Clark, are you here? Luke Ackerman, are you still here?
Present.
Present. Max Alderman.
Yep, I'm here.
Ella Caston. Henry Williams. Dominique, you're here. Ava Magnolia, I think you're here. Stephen Harp. Ava, you're here, right?
Yeah, she's here. Her mic doesn't work.
Okay, thank you. Stephen Harp, are you here? Brooke Lavelle, are you here? Kiara Lemon, are you here? Sarah Ormond, are you here? Ari Diaz,
Here.
I saw you. So
Here.
Sarah's here, Ari's here, Dhruvi Patel, I know you're here. Allison Kiernan, are you here?
Here.
And Dylan Williams. All right, kids, I have Eater, Mag, Phoenix Hines, Alex, I can't even say your last name. I'm so glad I did not try that. That would have been horrible. Steven Sakachu, Julia Coates, Walker, Ackerman, Alderman, Rapian, Magnolia, Ormond, Diaz, Patel, Kiernan, gotcha. If I didn't say your name, I don't gotcha. If I did say your name, thank you guys for sticking through this. This was a big lecture. It's a lot of material. It's a big week for us. I'm happy to be back. I'm lying to you. I am. I'm just kidding. I am happy to be back. I'll see you in lab both days this week. I'm excited. We'll have Rob Edgerton helping us. He's fabulous. He's a paramedic with the Folly Beach, the area beach lifeguards, and he's going to try to recruit some of you. That's a fun job to have. It's an EMT requirement job, and it's pretty good money too for the summer. And you guys will gain certification in time to do that if you want to get paid real quick for what you've learned. So he's going to be with us this week as well to help us out, and I'm looking forward to it. Everyone have a wonderful night. Goodbye.
Bye, Justin.
Bye-bye.
Wait, Justin, did you get me here, Shy?
I got you, Shy. I got you, boo. You can go.
Okay.
Bye-bye.
You are currently the only person in this conference.
Thank God I'm the only person. I can go home.
You are now muted.